So, like introduction, in recent years, management of the scapholunate injuries has been at the forefront of debates. Advances in wrist arthroscopic technique have redefined major anatomical findings and operative approaches. For that reason, there is better anatomical comprehension, and today we talk about the scapholunate complex. The scapholunate ligament complex uh, has three elements. The first element is the intrinsic portion of the scapholunate, and it has three segments, the dorsal, volar, and proximal segment. The dorsal segment is biomechanically the most important. The second element is the main extrinsic ligaments, such as the radiuscaphocapital ligament, long radiolunate and short lunate ligaments, and the dorsal radiocarpal and dorsal intercarpal ligaments. The third element of this complex is the dorsal capsuloscapholunate septum. This structure joins the dorsal capsule with the dorsal portion of the scapholunate, as we can see in this image, and we can see in the cadaveric specimen. These three structures are closely interlinked and appear to be the key of the scapholunate stability. For that reason, in 2011, Dr. Christophe Matula proposed this new technique. And the main goal of this technique is repair of the DCSS, or the dorsal scapholunate septum. And in this technique, they use the PTS suture, needle number 21, and consists in the first step, you first suture pass through the dorsal capsule and then through the dorsal scapholunate ligament tear in the lunate side, and this suture pass from the radiocarpal joint to midcarpal joint. The second step is the same way like the step one, but in the scaphoid side. The main advantage of this procedure is you preserve the dorsal capsule, and the muscle and tendon response to trauma in the dorsal and volar surface of the scapholunate exert a protective effect against the scapholunate dissociation. For that reason, it is very important to protect the dorsal capsule. Finally, we perform the knots. The first knot has been tied between the distal sutures, as we can see in this image, and then the first knot enter in the midcarpal space. Then the second knot tie between the two proximal ends and introduce in the 3-4 point incision. The reported 36 patients, and the mean delay from trauma to surgery was 90.8 months. The DASH score was from 34 to 90.5. All the patients returned to work an average time of 9 weeks, and the 7 professional athletes continued practicing at the same level as before the injury. Only 6 patients had occasionally slightly pain. This is the EWAS classification, and my presentation focuses in EWAS 3, A, B, and C. So I show you some cases about this technique. This is the first case. Male, 30 years old, suffered a wrist trauma. He had a pain in the dorsal of the wrist. During the clinical examination, we found Watson sign positive. He performed physical therapy for 2 months. However, the pain continues. This is the MRI of this patient. We can see the partial scapholunate tear, and we propose this arthroscopic dorsal repair. Firstly, we evaluated the scapholunate ligament, and in this patient, the proof entered between the scapholunate ligament in the dorsal segments. For that reason, we classify this patient in EWAS 3A. After that, we started to perform the arthroscopic dorsal repair. We passed the sutures through the dorsal capsule and then through the dorsal portion of the scaphoid, as we can see in the video. We use only PDS sutures and needle number 21. And after that, we retrieve the sutures in the mid-carpal space. And we perform the knots. The first knot is tied between the distal ends of the sutures, as we can see in the video. This is the first knot, and the first knot enter in the mid-carpal space. So this is the first knot, enter in the mid-carpal space. And we can see the knot in the mid-carpal space. So after that, we perform the second knot between the proximal ends of the sutures. And finally, the patient was immobilized with a short cast for 6 weeks, and after that, he started the physical therapy. This is the follow-up of the patient at 3 months. She had full range of motion without pain. This is the video of the patient. And he returned to work as before the injury. So this is another case, a female, 50 years old. She performed a manual work, had pain in the dorsal of the wrist for 9 months. In the clinical examination, we found Watson sign, and she performed physical therapy for 3 months. Nevertheless, the pain continues. So I propose in this case the same technique. First of all, we evaluated the scapholunate ligament. As we can see, the proof entered between the scapholunate ligaments, but in the dorsal side, so we classify this patient in EWAS 3A. We perform the same repair, and this is the final follow-up at 4 months. She had full range of motion. She didn't have any pain, and she returned to work. So there are some papers about this technique. In 2018, they reported 15 patients, and the mean follow-up period was 20 months. The scapholunate stability was classified in EWAS 3. Activity pain decreased from 7.8 preoperatively to 4.4 postoperatively. The final follow-up range of motion, inflection, extension, and the grip strength were estimated are 87 and 91% compared with contralateral side. Our experience, we have 4 patients. All of them return to work. All of them have full range of motion, and the DASH score was lower. To sum up, the scapholunate ligament, the extrinsic ligaments, mainly the dorsal intercarpal ligaments, and DCSS are the key of the stability in the scapholunate interval. The Willis arthroscopic allows precise diagnostics and treatment at the same time. The arthroscopic techniques are the least innovative surgical techniques for scapholunate ligaments. For that reason, we preserve proprioception on the dorsal side, and this playing an important role in the stabilizing the scapholunate space. Thank you.